technical difficulties. Okay, while we're waiting for this, I don't have a slide on it. Does any of our wonderful physicians want to talk about current standard treatment care for oncology care? So we'll talk about prevention and risk factors, but overall, what are just some current treatments? And then I know Jessica does a lot of work looking into kind of future treatments. I actually think Dr. Kogan probably does too, in the integrative side. Like what are current treatments and downsides of that, but upsides of that? Obviously, we know some of those things work very effectively. And then what do you think some future therapies are? And then I'm going to ask how we can include cannabis in that space and where you think it fits in.
Well, I mean, it could be a really long answer, so I'll try to stay very focused here. So I think the future is personalized oncology care. I don't think there's any discussion about that. I think unfortunately the current standard of care is still protocols, and often with complete disrespect to the patient's terrain. It's sort of like, okay, well, we researched this, this is what you're going to get, without sort of trying to sense, is this patient strong enough for the treatment, or other particular genetic modifications that are speaking to the specifics of a given patient. It's just at the beginning in some more innovative oncology practices, not our own university, I'll tell you that, unfortunately. But some of the more innovative oncology centers and the larger ones, Sloan and some others, they're kind of trying to go that direction, but it's kind of slow. And I think the strength, of course, when patient presents with an acute cancer that's kind of in a run amok state, I think the integrative approach is just not going to cut it. Often you really have to go aggressively after the tumor, and at the same time trying to maintain terrain, trying to help the patient overall to deal with the treatments. And I think that's where integrative medicine shines. You don't know how many times I hear oncologists, eat whatever the hell you want, it doesn't matter, which is like, all right, it's like, it's not 50 years ago, it's 2022. You got to know at least some basics of, the sugar metabolism, and like just some core principles, or at least if you're in a brain cancer world, you should look up the ketogenic diet for brain cancer. There's control randomized trials showing benefit. It's not a rocket science to do this, but they're in their niche. So their niche can be very powerful, but it could be limited. I think that's the whole point of integrative medicine, that we come in with the tools that otherwise not available for patients if they stick with the standard of care. And there are a lot of different things we can talk about that it can go different directions. I would say the one thing, that cancer doesn't show up in a random. Actually, Rebecca, will be a little bit critical of one of your statements, just one, where you said there's not a lot of control. We actually do have a lot of control over our risk factors for cancer, and they may not be very well understood. Some of them may be quite kind of out there. But many of them we do understand. The methylation as a risk factor, we understand. The toxins, we understand. Even though I was in a grand rounds yesterday, and there was a very well-known rheumatologist talking about risk of breast cancer in African Americans. That's his expertise. And he's like, well, maybe in the next 10 decades, in a few decades, we'll know the risk of toxicity. And so I'm like, oh my God, this is the utmost expert. Just look up the links between different toxins and cancer. So some of this we know, some of this we can look into, some of this we can do, some of it we can't, just because we know there's something there, but we don't know exactly what to do with it. So I think that's absolutely correct. And of course, the lifestyle, the lifestyle can be optimized at any point. It's not just the diet, there's a lot of other things. Cancer generally is the result and the cause of stress itself. It's a kind of a catch-22. The diagnosis is stressful. Treatments are stressful, everything around a cancer is stressful. The bills that coming in and pile up are stressful, everything is stressful, right? So, all of the management of all of those things end up often falling on our shoulders, just because it's just not what the standard of care does. And, we've learned over the years to integrate seemingly well, although the problem often comes in when there are competing priorities. And I think that's actually important for us to talk today, like at what point does the cannabis priority becomes a real priority, and sometimes even over the priority of the standard of care. We'll touch on that, because that's often I see patients struggle where an oncologist says, well, we got to concentrate on this, forget everything else you do because it's not important, and then you're like, no, it is important, just slow down. And So, but that's, I think, what we should start with.
Yeah. And I just want to add in, when I said uncontrolled risk factors, I think the universe is telling me to forget the slides, that they're not happening. I like to say that because, as we know, social determinants of health affect cancer rates and global cancer rates, environmental toxins, endocrine disruptors. And so those things I feel like are systemic things. So yes, is besides genetics, is some things in our control? Technically, yes, but because as we know, Monsanto, pesticides, endocrine disruptors in the food supply, particularly a problem in the United States. Because when people do everything right, right, like they wear sunscreen. So I was going to talk about that. Like, they have their vaccines, they have sunscreen, they're eating healthy, they're exercising, they don't smoke, they don't drink, right? And then they're devastated when they get an oncology diagnosis. And I think a lot of people don't realize how much things are out there, because I agree, diet does matter, and sure, environment does. Unfortunately, those things are systemic issues that are kind of up to all of us, especially I feel like those of us on this panel, to control or fight, push back against. But for most of the patients, they can't move. It's hard to access healthy food. Even if you do have access to a grocery store, some of the things in there may not be sold. So yeah. So, but I completely agree that we're not paying enough attention to food and everything.
I think the systemic injustice is exactly the right term. Basically people who can't have access to certain services, whether it's out of pocket or for the insurance based, but as a system a whole, you don't even, often people have a hard time getting into good oncology care, forget the integrative. They get treatments that are suboptimal, or they have no access to the sort of most up-to-date protocols, etc.
Right. So if Justin Ryan wanted to talk about like current treatments, and then Jess can talk about like a little bit of the integrative future treatments, and Dr. Kogan, feel free to join in. Sorry, Dr. Montalvo, I could use everybody's formal titles. Yeah, because I think, and then where you think cannabis fits in, and I would love to hear everybody's opinion about, do you see a future where it's an adjunctive therapy, used with the things we're going to talk about, chemo, radiation, what have you? Do you think it's only going to be for palliative and symptom control? Do you ever think it's going to become mainstream? And go.
Yeah, Ryan, go for it. Yeah, why don't you, as being hospital based right now, I think
Sure.
you're probably on the in the biggest mix of what's kind of still happening for standard of care.
Sure. I mean, the bulk majority of the standard of care are still, the older treatments, surgical resection, when it's appropriate, radiation, traditional chemotherapy, I think is still the bulk of a lot of what we're seeing. In recent years, obviously, a lot of immunotherapy treatments have started to really come to the forefront, which is great for targeted harnessing the body's own immune system to fight off the cancer cells in a more targeted way than kind of the general toxins of the chemotherapy are. Obviously, there can still be side effects when you harness the body's immune system. You can overactivate it and lead to kind of immune related complications as well. And just, highlighting what Misha said, I think the future of cancer care and what we're already starting to do is to kind of keep pushing that understanding of what the individual genetic mutations that have, led to this particular cancer in this particular tumor, and then being able to target that very, very specifically with the hopes of getting better outcomes and really minimizing the toxicity. And I think that's, what is so exciting, to be a part of kind of oncology care at this time. I feel like that really the next few decades are going to be a very, exciting, sea change in terms of what standard, treatment looks like. And I think it'll be a real benefit to a lot of folks. where cannabis is going to fall in there, I think is going to be a very interesting question. There certainly seems to be a strong role for it to help with symptom management and helping people tolerate some of these therapies. There's a lot of preclinical, so looking at things in the lab or in animal studies where cannabis may have some anti-tumor properties itself, and so how that will translate into real world applications in human patients is a really interesting question that I'm excited to be part of and to kind of look forward to.
Yeah, thanks for the refresher, Ryan. So I was thinking, I'm like, yeah, let me make sure that I'm still aware of where we are right now with the standard of care. And I think that this idea of a terrain that Dr. Kogan brought up is probably when we start to think about how cancer therapy and management is going to become personalized in the future, it's really about understanding, why did this cancer show up in the first place? What are the ways that we can really work with this cancer? And we're seeing there's more and more interesting testing that's coming out. For example, a lab based in Greece named RGCC that can look for not just evidence of circulating tumor cells before there may ever be symptoms, a tumor on imaging, but they can then also look at these cells and test them against both standard regimens, chemo, immunotherapy, as well as certain integrative therapies. And that could be, really spans the gamut, anything from a high dose of vitamin C to a curcumin, which is, a very anti-inflammatory agent, acts on NF-kappa B pathways, and so the list gets very long there. But to know that there really are options, they're again not in reach for everybody because insurance is not at a point yet where they're willing to cover this. However, when you meet somebody who has cancer or who they've received a diagnosis, and often I think in the space that I might see them, they are already seeing a medical oncologist. They've had at least a round of standard therapy, and again, I agree that you need to make sure that you put the fire out before you're going to move forward with therapies and approaches that are going to frankly take a lot more time to work, and they're going to be more energy intensive as far as planning and such than sitting in a chair and receiving an infusion. So I definitely think it makes sense to start there often, but to try to bring this integrated perspective in early. And I think that where cannabis is going to fit in, I think it's fascinating because what we see in animal models or what we see in a petri dish is not always what's happening in humans. And certainly the Society of Cannabis Clinicians course, lecture on cancer really kind of talks about this quite a bit. That we have some evidence, for example, that some THC may inhibit migration of certain breast cancer cells. Well, that's amazing to think about. But then there are also other too low, you may end up having an encouraging impact on the cancer. So I feel like this is where we really do need to get more data in humans, because I think what happens in an animal and what happens in the lab is not always what's happening in a human body. And again, I suspect that there's probably some of these terrain factors that are impacting how somebody might be responding to cannabis just in terms of their cancer, putting the symptom management aside. And we're not building studies yet that account for all of that, but I think we're going to need to be thinking about that.
Yeah, I think that's all exactly right on point. I just want to add a couple of things. So I do a lot of palliative care, and I'm actually in the division of geriatrics and palliative care. I think the cannabis is already way in there. We use cannabis with, as I said, at least half of all the cancer patients, maybe not directly as disease modifying treatment, but as a supportive treatment. And I always give this example. I even wrote a review article on this a couple of years ago, basically saying something along the lines of very similar to what Sunil Agarwal likes to say. I can give patients 4, 5, 6, 10 medications if they have complex symptoms around cancer: nausea, vomiting, insomnia, fatigue, depression, anxiety, chronic pain, of course, or I can just give cannabis. And the safety of that is so much higher I can list you, I can walk you through, say, 5 or 6 most commonly used palliative medications, and they all have mortality risk associated with them. And it's not just opioids, which are self-explanatory, but benzodiazepines. And even simpler things like Reglan, for example, is not that benign as people think. And so, cannabis is just way safer alternative. It's much more patient-centered, meaning patients can titrate the dose, they can figure out precise dose that makes them not just controlling the symptoms, but also just overall quality of life improves. In fact, you look at the studies and it's pretty fascinating what you find. You find that in the studies where cannabis is used, the quality of life is better than in placebo. And I don't know any medical treatment that will improve quality of life beyond the level of placebo. It means that you're not just not seeing side effects, you're seeing a general improvement no matter what the patient is going through. A lot of this data coming from Israel. We don't necessarily have some of this data in US, just, Israel has been doing research on this a lot longer. I think the future of cannabis in cancer is gonna be definitely into disease modifying. I'm not gonna be afraid of saying that the craziest cures I've ever seen, every single one of them involved cannabis, every single one. I'm yet to see a single crazy story. And, we have 2-3 crazy stories a year. Like, let me give an example. We had a 61-year-old guy with a colon cancer with metastatic disease everywhere. We put him on a high dose vitamin C and a high dose RSO, both rectally and orally. And he went for debulking surgery. They opened him up and they closed him up. And I get a call from surgeon saying, I have no idea what just happened. Either I have a wrong patient and then I'm quitting my practice, like literally that's what he said, or you did something beyond what I've ever seen in my 35 years of practice. And so we all seeing this unexplained cases like this, we all seeing crazy stories like this, and we just can't put heads and tails. Why is that guy does it and somebody else just dies just as predicted? No idea. I think Jessica started pointing out that some of the kind of a future where I think it's going, which are this much more personalized pieces of data. We're not there yet. The test is like what, $5,000, I think. So like most people will not afford it. And frankly, we don't use this test. We've seen this test in use, and I'll tell you, it's just not as great as people expect. It's a matter of moving forward. And I think the other huge point is with the actually figuring out how cannabis fits as a disease modifying agent. I think we're actually going to start seeing studies, because there's seemingly a shift at an NIH level and private funding. Partially it's because there is a signal and everybody knows this, and they can't suppress it for like indefinitely, right? Like information leaks out, patients talk about it, there is some funding, and pharmaceutical industry is not stupid. They seeing a potential here too. So we're going to see different angles of approach here. And I think it's just a matter of time before we're going to see specifics here. Meantime, it's kind of a wild, wild west out there. And I think that the clinicians who do this carefully and very precise and try to really, not just over exacerbate the claims are far in between, unfortunately. So we're probably going to be in that weird transition time for a long time, for like probably many years before we get some sense of exactly. But meantime, I have absolutely no hesitation to tell everybody, use cannabis for symptoms control. In the worst case scenario, it's not going to help your cancer, but you're going to feel better. In the best case scenario, it'll help your cancer. And okay, well, you got that benefit anyway.
So that's perfect. And that, I hope my internet isn't too choppy. That leads me into my next question, which is with the rescheduling potentially now of cannabis as of yesterday, what do you think is going to happen to research with cannabis in oncology?
I can start. I think we're going to see explosion. I think it's already cooking toward explosion. It's enough to just say that NIH just put out a call out there saying, look, we need to hear from all levels of academia and private industry of how to make this better. So they're actually asking right questions. So there's already a boom happening. I think the moment it's descheduled, it's just going to go like instead of like that, just like that. And I think it's more important, not just rescheduling, descheduling, and who knows what will happen. We've heard this conversation before, so I'm gonna be optimistically cautious that things will change, but I think they will. It's just a matter of time. And I think more important than that, not just the fact that it's going to grow. I think the critical aspect is, where is the funds going to come from? If the fund's going to come from industry, that's going to be self-serving purposes, and we do see a lot of that. But I think we have to see that the public gets out there and speaks about it and saying we need federal funding, because that what will actually move the needle better. Otherwise, we're going to have a lot of commercial interest and kind of filtering out some of the pieces of data there may not be as easy as people think.
Yeah, I certainly agree with Misha. I think that the opportunities for research are about to be much, much better. So currently, cannabis is regulated as a Schedule I substance, meaning it has high potential for abuse with no medical therapeutic benefits. It is on the same list as heroin. Cocaine happens to be Schedule II, along with other things like fentanyl, morphine, oxycodone, things like that, medications that are considered some therapeutic, some medical therapeutic benefits, but high potential risk for abuse, and therefore they need to be more regulated. So what's being talked about is potentially moving cannabis from Schedule I to Schedule II. What that will allow, because there's no longer this idea that it has absolutely no therapeutic benefits, which with, so many, 30 plus states already, have already identified potential therapeutic benefits. It's kind of been a little crazy that it's been kept it at Schedule I this whole time, but it will allow for there to start to be federal funding. And I think there is this huge interest in it. It's just been so onerous for anybody in the United States who wants to get that federal funding in order to do this research, in order to pursue it, that this will make things a lot easier. I think I don't know all the ins and outs, but right now, if you are going to study cannabis through that through that mechanism in the US, like all of it comes from a single source, basically farmed in Mississippi. And I think that this descheduling will allow there to be more, more flexibility in terms of like what, providers they're able to get, cannabinoids from in order to study a wider variety and a wider variety of settings. So Misha, I definitely agree with you. I'm very excited. If, again, we've had the Lucy football moved on us, before, but if this does happen, I think the ability for researchers to get that kind of federal funding where they can do, the research that needs to be done, I think is just going to be huge.
Yes, and again, I would also agree that this is going to be huge just for access, and what I hope happens is that a lot of researchers, I hope they sort of really take advantage of this unfortunate situation we have with opioids, where unfortunately there are a lot of downsides and a lot of good points about opioids depending on the situation. But when I sort of think about trying to sell this, so to speak, for federal funding, I think that something that the federal government would like is for there to be fewer opioid related deaths. I think that we would like to see that the opioid epidemic is actually improving over time. And we have really good data that cannabis, and I think a lot of anecdotal data, that cannabis, whether for addiction or for somebody who's using opioids for whatever reason, that often we can decrease the opioid use and use of other meds, as Misha was saying, things like benzos, which are not, certainly not benign. A young person being put on benzos, for example, having an increased risk of cognitive decline as time goes on. I mean, we have a lot of reasons to try and get away from some of these pharmaceuticals that we've really been leaning so heavily on. And I hope that those themes, will be used as justification, because I think that might help with getting some funding.
Awesome. Thanks, everybody. So my next question is, when do you think a oncology patient or somebody with risk factors for any type of cancer diagnosis, when do you think cannabis should be started as, let's just talk about either part of a wellness routine for somebody who maybe is young and healthy, or even older and still has no past medical history, Or once there's a diagnosis, when should cannabis integration begin?
I can start. I think it's very patient dependent. I don't know. I think the sooner the better kind of general principle, but depending on what actually is going on, I would say if there is no symptoms and patient's doing really well and it's very early in diagnosis, I may not necessarily jump on this right away. I may say that other priorities may take place, especially if we're going for aggressive cure and the treatments. Like I can give a couple of cancers where I think I wouldn't think of cannabis right off the bat, like something like lymphoma, leukemia, and there's really not a lot of symptoms and it's early and it was identified on tests, not on this patient's symptoms. So I may just go aggressively with toxicity workup, identifying underlying drivers if I can, modifying them and then putting person on a good lifestyle, and then some basic supplements like maybe EGCG and turmeric. I think that Jessica mentioned a few other things like that. But if the patient comes in with a lot of symptoms, oh boy, I mean, I think the cannabis often goes first line nowadays, for me at least. Often I would explain to them, I'll give them choices, and a lot of patients just go with cannabis first. But of course, we're biased providers, right? So people come to us for a reason. So, if I were to sort of say on average, I'm assuming that most patients would not think of cannabis as something right off the bat, which I think is unfortunate. I think a lot of the times it would make a lot of sense to start specific products for specific issues, just so that you minimize risk of other concerns. Unfortunately, what was just said, that basically a lot of people end up on opioids way too early, in my opinion, and we know the risks of those medications, and I wish that everybody would substitute. And like a sleep, for example, that's almost universally disrupted in cancer patients, and it's not only because of cancer, but because all the cancer treatments tend to cause horrendous hormonal shifts, and big part of the hormonal shift is entire melatonergic pathway gets off, and just giving melatonin is barely not enough, even though we give it always, because melatonin decreases risk of cancer progression and metastasis. That's a known fact, high dose. But that's where I think cannabis shines. And again, I'm not giving specific formulas. I think that's not the point of this conversation, right? But again, all of these things that go very quickly into very specific directions and according to what the current patient need, I think that's the key.
Yeah, I actually exactly was thinking so much about the sleep part of this, because yes, it is the one thing that seems probably common across all cancer patients. Whether it's just the anxiety of having this diagnosis, going through these treatments, or side effects of the treatments, or the cancer itself. And I have a very low threshold. I mean, I pretty much start anybody who is having trouble sleeping. I will always start with CBD, but I will move usually pretty quickly to a cannabis CBD mixture. I'm done there, because good sleep, adequate sleep, is going to be important for them tolerating the treatments, for them having the best possible outcomes. It's obviously sleep is one of those pleiotropic interventions. It's going to have impact on so many things. So we really should, I think, prioritize sleep more than we do. And I feel sad when I see some of these people again getting stuck on sort of these short-acting benzos for sleep, or the sort of so-called Z drugs, your Ambiens and whatnot. It really doesn't make sense to go there first. I think again, cannabis is just way safer. Way safer.
I think before Ryan goes, I just want to throw something in. There's a data that when you look with that, not in randomized fashion, just look at the observational cohorts, people who take cannabis tend to do a lot better with cancer. Many of us wonder if that's the reason. If a lot of people end up either self-medicating or having a recommendation for cancer, and if the sleep in cancer patients is disturbed, we know that mortality is a lot worse. And we know that Ambien doesn't improve the mortality. So treating this disturbed sleep with pharmaceuticals does not change outcome of cancer mortality based in sleep. And the critical aspect of sleep, it basically an unnatural detoxifying strategy. And it's essential for longevity, not just overall, but specifically in cancer. There's a lot of studies on that. So I kind of just wonder, it's not a placebo effect that we see in cannabis associated with better cancer outcomes in all cases combined, and that's probably why. At least that's one of the.
Yeah, absolutely. I mean, I just echo what both of you say. I mean, I think certainly for patients who are starting to develop symptoms either from the cancer or from, you know, side effects from the treatment, I think earlier integration, I think, will be really helpful. Certainly by the time I'm seeing people being admitted to the hospital for symptoms, it means that they have had horrendous, poorly controlled pain, nausea, weight loss, not sleeping for weeks and weeks, if even longer. And then by the time they get admitted and then being admitted to the hospital, it can be, you know, challenging to try and improve, you know, some of these things. And obviously, like, you know, our ability to, you know, utilize cannabinoids on an inpatient basis is, you know, extraordinarily limited. But yeah, no, so I think that like earlier integration to try and head off some of these, you know, really severe symptoms that are very common kind of across the board for a lot of oncology patients, I think would be great. For some of those that we're starting to see more and more of now, I think, you know, the outpatient, both oncology and palliative groups, I think are starting to incorporate this a lot more. And yeah, I agree with Misha, whether it's the sleep or the ability to tolerate, you know, the chemotherapy and not have to, you know, take breaks and not have to have dose reductions due to toxicities and nausea and weight loss. I think there is definitely a possibility in there of seeing some outcomes, you know, improvement in outcomes related to cannabinoids. It may just be, you know, the improvement of the quality of life of the symptoms, you know.
I hope that the rescheduling of cannabis will someday mean you can use it in the hospital. I found that that was one of my most annoying, one of the things I hated the most.
Sure. It's definitely a possibility. I, you know, obviously there's a lot of talk on, you know, what does this, you know, if it moves down from Schedule 1 to Schedule 2 versus, I know a lot of advocates are just saying just deschedule it completely. I'm sure what we're going to see as it moves to Schedule 2 is it becomes in this like now pharmaceutical, at least at a federal level, pharmaceutical phase. We're definitely going to see pharma companies developing synthetic THCs that they're going to want to patent and use for prescriptions. I've read some, I don't know enough about the regulatory framework, but dispensaries and things like that may now need to register under as pharmacies and things like that. So there are some complications in this realm if it does move from 1 to 2. I think there's benefits in terms of research, but obviously there's always consequences, maybe intended, maybe unintended. But the ability to start to and study and utilize some of these things on an inpatient basis, I think would be, yeah, I think would be extraordinarily helpful in a number of cases. Yeah.
Ryan, what's going on now in your hospital? Like, are you any of their patients can use it if they already have the card, and if
I mean, right now we are prohibited from even things like CBD, CBG, even things that are hemp derived and thus, you know, not subject to that same regulatory framework. Right now, all of that is kind of prohibited for patients that are inpatient. We can
that's because you guys federally funded partially.
You know, I have not been at those high level discussions, but my guess is that is the reluctance for a number of hospital facilities that they do not want to run foul of the federal, you know, DEA regulation of kind of where a lot of these things fall. Yeah.
Yeah, we actually decided, I was leading the committee at our hospital on this, and we're allowing patients even THC, but obviously non-smokable. We don't even have balconies for them to go, so it has to be all, you know, ingestible. So they are doing it, but we don't write the card, so patients will not be able to get it if, let's say, I come in, I say patients should be on
Yeah, so that's yeah, so if any of your institutions want to get on board, I've been kind of seeing what palliative care groups want to give this a try, because yeah, when hospitals see changes in their bottom line, when Medicare is made happy, that's when we start seeing more integration of kind of newer therapies. My next question is going to be, so this is, how does cannabis help us in
hurt us. We've talked about a lot of ways that it can help us. So on to the potential for hurt. And I feel like the hurt comes with gross misinformation and the fact that we are being led by capitalism and marketing in cannabis and a lot less by science. So I have an example. So this is RSO. So if you are watching this live or later, so in this teeny tiny syringe, this is about 300 milligrams of THC. Who could handle 300 milligrams of THC? Very few people. The only type of patient that could take this and be okay in one swoop is probably somebody who's been using medical cannabis or recreational cannabis for years, if not decades. There are some people whose receptors, everybody has a different recommended cannabis dose, but 300 is probably too much for a majority of people. So RSO is something that has a lot of buzz in the oncology community on the patient side. There's a lot of rumors saying that this particular teeny tiny syringe, RSO is also full spectrum cannabis oil. So this includes all the cannabinoids. There's 162, but there's a lot of rumors and myths that just using this can, and I'm going to put this in air quotes, cure cancer. Now, we know that we don't really know anything outside of the traditional treatments we talked about that can cure cancer. How do we use things like full spectrum cannabis oil, RSO? How do we help people use this responsibly? How do we fix the misinformation, essentially without upsetting people? Because while patient testimonial is important, we clearly don't have the study. So how do we go forward, kind of looking at this, dispelling the myths, and how do we use this teeny tiny syringe to help patients accurately dose this properly? What says everybody about these myths and RSO, and can we take something that's kind of gone off the track of a myth and turn it into something based in research and positive?
I feel like I always go first. Maybe somebody else want to go first.
I'll give it a shot. I mean, I don't know that I have the answer as to how to correct misinformation. If I knew that answer, then I'd probably be at some very elevated position of authority in this country. But I think that in terms of the point about how it might inform research, how can myths inform research? I mean, you kind of wonder about there's not always a lot of interaction between shall we say kind of more community or social media based cancer groups, survivorship groups, and what's happening in research, right, which tends to be very academic and behind closed walls. And you kind of wonder about actually trying to build some collaboration. We always hear about how you need to do a needs assessment before you decide maybe what you're going to teach somebody, what you're going to tell them. And I almost think that maybe something like the RSO myth would be an opportunity to try and understand from the, call it the consumer or patient perspective, what are their questions, and what and how can we perhaps start designing small prospective trials that don't have to be 10 years of like longitudinal data, but how can we start designing some small trials that might help answer some of these other questions about the role of cannabis in cancer, and also address what it can do for an average person, knowing that everybody's their own N of one, but on average what happens with people's with their longevity, what happens with their progression of disease, as well as the symptoms. So I think that it would be nice to see some more collaboration there.
Yeah, I mean, I completely agree with everything you said. I think the best is to follow the data and to follow the evidence and really explain that we don't have evidence. I rarely give the actual anecdotes to patients unless they specifically ask for them, just because it's very misleading actually. And I can speak about this in the group because that's needs to be said, because if you see signals like this, they have to be researched. But on an individual level, when there's a lot of lack of clarity, you really have to be quite specific. You know, certain things in integrative medicine do have more evidence. So for example, vitamin C has been studied by Mark Levine and some others and ourselves too for probably about 35 years. And so we know, like, yeah, it definitely improves outcomes of certain types of cancer, like for example, ovarian and pancreatic. There's been just randomized controlled trials done. But beyond that, in cannabis, you really can't say. So you have to be very, you know, very clear about what evidence shows, and then, but then be also at the same time patient-centered, because I think there's something to be said about patients' belief and not to dismiss them offhand and be safe but supportive. I think integrative medicine starts and ends at this principle of, you know, meet the patient where they are and work with that and try to adjust the expectations if you have to, but, you know, not necessarily. People in the standard of care get bombarded with very strict messaging, and I don't think they want to hear more of that. I think you just have to be very tactful and clear what's possible, but at the same time, you know, do support to the maximum. And I think that there's nothing wrong with saying, look, we don't know, but if you really want to try, we'll go with you wherever you want to go. I'm extremely open about this, as long as I think the safety is there. So that's the only thing. If I'm worried that somebody is going to take 500 milligrams of CBD per day because somebody told them so, and they're on 25 medications, I may say, you know what, that is not a good idea, because you can't keep all of that CBD sublingual. It will go through the first liver pass, and God knows what interactions with medications you're going to end up with. And actually, there is some hints of problems, right? So a couple of months ago, I gave a journal club at Cannabis Clinicians, and I reviewed the article, the Israeli article, that sort of, it's not necessarily clear. They looked at the cannabis users in combination with some of the newer disease-modifying biologics, and actually patients who use cancers did a lot worse. Now, I critiqued the study because there were some gross, you know, omissions and some other problems, but, you know, we have to pay attention to this. If there is a negative study like this, it needs to be understood, researched, and we have to move on. So we have to assume that anything that has benefit can have a side effect. And here is the critical aspect of cannabis. We all know that it's a J curve for almost all conditions, right? So whatever works at the small dose, when you get on the other side of a J curve, like nausea is a great example, then you may actually cause the problem you're trying to address. So we have to be careful. We don't know. I mean, we don't have a lot of answers. And so if the patients want to experiment, I think that's fine, but we have to really also do no harm first, and watch, monitor, and be very aggressive at being clear that experimentation has its limits.
Yeah, I'm glad you brought up the immunotherapy point, because that's exactly kind of where I was thinking a lot about. Just there's this, you know, idea, and, you know, not unsubstantiated, that, you know, cannabis, you know, does impact T cells. It does impact, you know, what happens with these cells. And so if we're trying to really use those cells to fight a cancer, then, you know, we may get into trouble sometimes. And I think another sort of example that sticks in my head with this, whereas we don't want to do harm or need to kind of understand more about what we're doing, is tamoxifen. That, you know, for tamoxifen, you know, needs to be, it's a prodrug, right? It needs to be metabolized to actually be impactful in the body. And because THC interacts, you know, most likely with like the same CYP450, you know, enzyme that tamoxifen has to go through, you know, of course, you know, everyone's intentions are good. You just want to make sure, though, that you're not inadvertently decreasing, you know, the impact of someone's tamoxifen by using cannabis. And I think that, you know, this is where I think the dosing, you know, and just kind of the open discussion of saying, you know, this is what may be true. We don't necessarily have all the data we need, you know, and then this is where you have to, you know, kind of discuss with people, what is their risk tolerance? You know, what is their, you know, bigger priority as far as if they're managing a particular symptom, you know, issue versus trying to give every possible chance to have a cancer remain in remission. You know, what is kind of their priority in that moment?
Ryan, do you want to add anything?
And I know we're running out of time. Not a lot.
Yeah.
I don't have a lot else to add, but yeah, no, I mean, I think Yeah, summarizing a lot of this ones, I think, education, collaboration with the patients, and then being very clear about what we know and what we don't know, because I think that's, a key thing going forward. It's great for patients to have hope and to read about these things. And I think a lot of these kind of case reports and anecdotal studies are great hypothesis generating ideas that, hopefully then can lead to research that, we shift the pile of what we don't know into what we do know. And I think that would be really important.
Great. One bigger question I wanted to ask, because so a couple of things, and I'm so happy that we have such a great group of physicians that are super smart to help our nurses move this work forward. So I'm really appreciative of everyone on this panel, and I hope we get to do this again as well. But one of the reasons that even got me involved with cannabis is bye, Dr. Kogan. And I'll do a blast of everybody's information. He has a fantastic book, so this will be recorded and shared on YouTube. Definitely check out his book. And so one of the reasons, going back, why I started this entire kind of clinic and education firm is I really cared about the advocacy about patients who didn't have the resources to kind of advocate for themselves. And so globally in the United States, if you are not in the top 5% of income bracket in the Western world, and then it kind of goes down from there, your care is different. It just is. So that really bothered me. We do see global disparities in who has cancer, who has a higher risk of death from cancer. And that, of course, is globally actually women. So I started this education clinic to advocate for patients, but also low key, do what we can fighting kind of injustices and making systemic changes. So globally, because we know women, particularly low income women in the global South, are much more affected by breast cancer and cervical cancer, and even a lot of the preventative cancers like cervical cancer. They have a higher risk of mortality, and this affects the individual incomes of countries in the global South, and actually affects local and larger economies. We even see disparities here in low-income communities. So here's a real kind of interesting question, and feel free to expand beyond kind of medical uses of cannabis into if anywhere in agriculture perhaps could help this. But do you think there's a chance that cannabis as an adjunct therapy, symptom control, or even farming techniques, what can hemp do globally for workers, perhaps, the environment? How can cannabis help with this huge global disparity? Do you think there's any hope to kind of use cannabis to close that gap up a little more? I know it's a big kind of interesting.
It's a big question, Rebecca. Yeah. Now it's like you're taking us from just our simple practice to to the global impact. I mean, what I would think of is that I feel if we can have a better understanding of the situations where cannabis is most impactful beyond just symptoms, because I think we can all just agree. But if we're going to start talking about actual modification of disease state, disease like activity, then if we can better understand where it applies there, I think you do have some real ability to start closing certain gaps with certain diseases, be it cancer, be it inflammatory bowel disease, places where it feels like we have at least some signal to suggest that cannabis can do something in those situations. From the sort of more supply chain and empowering the workers part of it, I suspect that if we can keep the operations small and prevent the massive corporatization that seems to kind of signal the death for workers' rights, like the Amazon effect, right? So I think if we can try to stay away from that model, then there is an option for this to possibly become a more just work life for people, or there's a possibility, I think, there, as the demand grows, we're going to need to grow this more places. Well, we're going to need to, how we grow it's going to matter to the environment, and how we're treating those people matters, at kind of every level of society. So possibility, but man, we're going to need a lot of people beyond just those of us who are trained the way we're trained here.
Yeah.
Yeah, for sure. I mean, I don't think I have a whole lot more to add other than what Jess already eloquently said. I think that I think understanding more what the possible disease modification effects of cannabinoids might be, I think that may help with some of the disparities that currently exist between kind of more standard pharmaceutical based therapies and the struggles of getting that to everyone who needs it. And then certainly, again, if you're able to, utilize some of that plant-based medicine in kind of the look that can be produced and managed in local communities, there are definitely possible benefits for local economy, local environment, things like that.
Yeah, and because my hobby and my work overlap quite a bit, so my hobbies is just global health and feminism and how that intersects. So my hope for the future is, we have trouble getting much needed drugs to the global south and any kind of low income community in the state. So particularly for home, I hope as cannabis becomes more and more legalized throughout states, I hope more healthcare companies are brave about public-private partnerships, because, with some of the just for symptom control, opioids, there's no free lunch. NSAIDs have their problems, opioids have their problems. I've seen a really cool slide on tramadol called Tramadont because it increases mortality. So if we can get less hospitalizations, just from plain medication side effects for these low-income communities, I think that would help out. Just kind of, I feel like that's an easy action item. Plus, if cannabis is more affordable, if we get to that place, if people grow their own, right? I think there's a place to also save cost and have something consistently that people can use on the global scale. Because of pharmaceutical patents, this is what actually restricts, things like AZT for the HIV crisis in Africa, restricted the vaccine from getting everywhere and caused a lot of mutations. What I am hopeful about for cannabis is, I don't know, because it's such a cool botanical, and as Dr. Kogan talked about, like Marinol just doesn't work as well. I think cannabis will not work as well synthesized, so it will have to stay in the plant form, which means no one can really patent it, right? And I think that's going to be the benefit for the global community. If you can't patent it, you can't restrict it, and you can't drive up the price to where somebody in Sudan can't afford it, right? Cannabis is indigenous to a lot of these places. So if we could teach folks how to grow, there's certainly a benefit to growing their own, plant-based medicine to control side effects. And then I also question, will responsible agricultural farming of hemp, as it becomes more used for perhaps biofuels, textiles, what have you, will that help the environment? Will that decrease environmental factors? I know we are short on time. This is probably a completely separate webinar that we should probably consider doing at one time. But if anybody from the audience I know has a question, feel free to add in the chat. Hopefully we can do another one of these one day, but I think it was really great to have more of a physician perspective on the future of this and how this can help. And I'm always happy to do this again. And thanks everyone for joining. I did figure out how to screen share. So I'm going to put up, if my computer wants to be kind, just our information. And so you could see who we are and everyone. So I apologize for the pokey thing, but this will be on our YouTube channel. This will also be on probably our Instagram live, and that is, let me think, our TikTok is Acute Chronic RN, And our Instagram is Acute on Chronic 420 RN, even though we work with physicians. And then our YouTube channel is Acute on Chronic, and you can find it there. Oh boy, my slides don't want to work today at all. But you can see the names of us right here. And I was trying to get, if anybody wants to reach us, you could just go to www.acuteonchronic.com. All right, I apologize. The slides just don't want to do what they're supposed to do. But thanks everybody for coming to this webinar, and feel free to tell your friends and family to catch this differently. I want to thank Curaleaf and the Rooted in Good program for sponsoring us to do these kind of talks and share it throughout their network as well. So thanks everyone, and thanks everyone for coming. Have a really good Friday.